so we are going to talk about cannabis policy, and we're going to do this in the context of sort of a historical narrative, but ultimately, all of the discussion will center around patient care and what we really need to achieve and improve upon in order to do better by our patients. This is my slide about myself. Yes, I went to Harvard Medical School. I trained in internal medicine at the Brigham Women's Hospital, and I practiced medicine for 15 plus years at the VA in the emergency department. And that's sort of what led me, frankly, into this interest in cannabis care, recognizing that, in fact, I'd seen vast numbers of veterans who had been harmed by drugs and alcohol, and I really mean alcohol primarily, and never really seen anybody harmed, at least in the emergency department, by cannabis. I'm well aware that those things have changed a little bit over time, but nonetheless, that led me to think a bit about its relative toxicity and delve into several years of research, which led me to the conclusion that cannabis and cannabinoids more properly can be used as a medication, but that as any medication, it needs to be used carefully and thoughtfully to maximize benefit and to minimize the problems that might arise from there. That led me to the realization that I was amongst fairly few at the time, this is back in 2012, that had developed any interest or knowledge on the subject. And I formed InhaleMD, which is my private practice, to be able to bring this kind of care to patients, as well as then to be able to turn around and go back into the hospitals where I was faculty and start to educate my colleagues. And that morphed, as you've seen, into the Association of Cannabinoid Specialists. So we're going to start with a little bit of a quick review. I also should say that this slide deck is brand new. So there may be a few rough edges here and there, but bear with me as we go through it. The point of this slide, which is also perhaps just a few years out of date, is really to remind us of the landscape here. The dark green are states which have both medical and non-medical use. The lighter greens are medical use only. The yellow states are the ones that are kidding themselves that they don't have THC, but low THC is the name of the game. And then there are the few holdouts there in red, which have nothing at all for anybody. We also should take a moment to remind ourselves that the Controlled Substances Act provides 5 schedules onto which controlled medications go, and that cannabis is presently in Schedule 1, which is defined as substances that have a high potential for abuse and no medical accepted use. And we'll talk later about how that landscape is changing, but that's sort of where things stand at the moment. So if that wasn't a history lesson, let's get into some more history. The first thing is that amongst many of the cannabis advocacy folks, it is very fashionable to talk about how cannabis has been used for medicine for thousands of years. And, you know, that is unfortunately a little bit of a gilding of the lily. There is very clear evidence that cannabis was used in ancient cultures, including China, Egypt, and India. On the other hand, it's not so clear how they used it or how much THC there was in that cannabis. And so to say that it has been used as a medicine for thousands of years might be just pushing it a little bit, at least by the concept of medicine that we have, you know, in a modern society. So in reality, we really started to think about cannabis as a medicine as recently as 1837, when Dr. William O'Shaughnessy returned to Britain from his post in India, where he had seen people using cannabis as a medicine, and he began to grow and treat patients using the cannabis that he had brought back. Use of cannabis as a medicine of one form or another was then widespread sort of by the late 19th century and prompted 2 governments to run safety studies on this. The first was the British India Hemp Drug Commission, from 1894. And their conclusion of this was, quote, it's been clearly established that the occasional use of hemp in moderate doses may be beneficial, but this use may be regarded as medicinal in character. Subsequent to that, the United States ran its own trial called the U.S. Panama Zone Report in 1925. This was a study of service people, I guess at that time you could say servicemen, in the Panama Zone. And their conclusion was the conclusions of the report were that the deleterious effects of marijuana have been exaggerated, and it is recommended that no restrictions be placed on the use of the drug. And there are two references at the bottom. And I think this is particularly interesting in light of the fact that the next major event was, of course, the outlawing of cannabis not that much longer in 1937. Many of those studies and the medications that were containing cannabis at that time really stem from an era of what we call patent medicine, right? And this is generally felt to be an era between 1865 and 1934, and it was characterized by the development, oftentimes on a local level, of products that were touted for their medical benefits, but also really were not particularly controlled. And so we saw a lot of unsubstantiated claims, both from the sellers and from the manufacturers. There was no concept of quality control, so products were variable from one batch or one bottle to the one to the next. And then we saw all range of contamination, and in worst case, even what we call adulteration, which is the deliberate contamination, if you will, with things like laudanum and other opiates, arsenic, mercury, and sometimes lead, all of which are severely toxic to human beings. On top of all of that, there's really no attempt to prove efficacy, so that the idea that these things might or mightn't have worked is really unproven. I must admit, I've peppered a few of these little cartoony guys or memes in here just to break things up a little bit. So in 1934, the FDA was born, and it was formed for the establishment of safety regulations to require that medications meet certain standards for safety. They also standardized things like dose measurements so that people could know what they were taking and how much they were taking, and to get advice from their clinicians. They defined a prescription as having certain key ingredients that are important to the dispensing, accurate and reliable dispensing, things like the medication name, the dose to be taken, how often that should be taken, and the route of administration. And I think most, well, maybe not most importantly, but certainly very importantly, the sales amount, which then leads to some protections on a financial level. So this established sales limit and addressed conflict of interest that we saw in the sellers. And then, right after that, and unrelated to the formation of the FDA, in 1937, we started to see prohibition come along with the Marijuana Tax Act, which was a federal act. Unfortunately, my home state of Massachusetts was the very first state to impose limitations on cannabis use back in 1911. So this has clearly been sort of brewing along for quite some time. So cannabis was no longer used as a medicine. The American Medical Association at that time objected and testified, but nobody listened, because who listens to the doctors anyway, right? On the other hand, research continued, illegal or otherwise. So THC was discovered in 1940. The structure of THC was elucidated in 1964 by our friend Raphael Mechoulam. And THC was isolated and then synthesized in 1968. In 1969, there was a Supreme Court involving Tim Leary that struck down the Marijuana Tax Act. Unfortunately, the federal government saw this coming and was quite prepared to act, and in 1970 instituted the Controlled Substances Act, which has had some major positive impact, but the Schedule 1 was largely used as a political tool, and cannabis was unceremoniously and without evidence dumped into Schedule 1, and that continued prohibition and continues prohibition to this day. On the other hand, I want to point out that we have tons of data. And to me, there is a certain irony in the fact that the Controlled Substances Act prohibited cannabis use. And here we are on the slide that showing that only a few years later, we have a bunch of studies showing medical use, right? So in 1974, we have a randomized controlled trial showing pain benefit from non-cancer pain. Also in 1974, we see a randomized controlled trial showing benefit for spasticity in spinal cord injury patients. And in 1975, we have a randomized controlled trial showing benefit for pain, for cancer pain, and particularly interestingly, at doses as low as 10 to 20 milligrams, which sort of sets the stage for modern approaches now. Now we're going to fast forward a couple of decades and start to talk a little bit about the start of state programs. So as you all know, 1996, which feels like yesterday to me, which is why I stuttered for a second, but in fact is quite a long time ago, California became the first state to legalize cannabis for medical purposes. At that time, it was probably not unreasonable for physicians to be afraid of losing their DEA permits or going to jail for, quote, aiding and abetting. And so it was that the solution at that time was to minimize the physician's role simply to attesting that the benefit likely outweighs the risk. I think that that is a very inappropriate standard for today, but that was what seemed to be necessary at the time. 2000 to the present, nearly all of the states have rolled out their own program. None are exactly alike, but all have significant similarities and problems, some of which include that there are little or few data behind the qualifying conditions. Most of the qualifying conditions are actually politically determined more so than scientifically. There's only the most basic safety regulation involved. There's no standardized dosing. There's no process by which practitioners can control the process of sales to ensure that patients are getting what they need and only what they need. And there may be some continued fears over federal intervention, though I think that present administration yet to be seen, up to now, we've seen that that has become less and less of a real issue. In 2013, the Cole Memorandum came into place, which set priorities for enforcement, or as the case may be, non-enforcement of federal cannabis law. This set out what I think most people would consider to be a fairly common sense set of parameters, including things like let's not give marijuana to minors, let's prevent money from marijuana sales to going to criminal enterprises, let's not have marijuana diverted from legal states into states that do not have legal cannabis. Let's not have cannabis businesses become a front for other sorts of illegal activity. Let us prevent or prioritize the prevention of violence and firearms in the use of creation or cultivation of cannabis. Let's do what we can to minimize drug driving and adverse public health consequences. Let us think a little bit about environmental protection and particularly on public lands. And then the last one here is prevent marijuana possession or use on federal property. And I want to call particular attention to this because we're going to circle back to it in a few more slides. And this really set the stage for sort of more free development of states' programs. This was embodied in a law through the Rohrabacher-Farr or Rohrabacher-Blumenauer Amendment, which interestingly was first introduced in 2001, but only passed in 2013. 2014 and basically prohibits the Department of Justice from using their funds for interfering with states' medical programs. And then the Farm Bill happened in 2018, and I think that this certainly complicated things considerably. The first thing we have to understand is that hemp is sort of a fiction, if you will, which is to say it is something that is defined, but is not really a biologic thing. That hemp is cannabis, but that doesn't make THC or has less than 0.3% by dry weight. The Farm Bill went so far as to legalize hemp, but also all of its derivatives for any purpose. And perhaps that was unwitting, but it was clearly a very sweeping and broad statement. That made all natural plant-derived cannabinoids legal, for example, CBD and CBG and many others. But it also paved the way for what we're now calling semi-synthetic cannabinoids, which are cannabinoids manufactured from plant-derived CBD. And these include things like D8 and D9, THC, which are in fact naturally occurring, but at either low levels, as in D8, or is prohibited if it's directly from the plant, as in D9. And then there are a bunch of chemicals that are completely novel, like HHC, and the list is really extensive because in reality, the basic chemical form of THC and CBD is very extensible. And so you can manufacture from CBD a limitless, essentially, array of chemicals, many of which have never been seen before, and about which we have no real information whatsoever. And yet here they are putting these things on the market. Unfortunately, the Farm Bill provided no regulation for safety nor for efficacy. Subsequently, studies have shown us significant byproducts and contaminations in hemp-derived semi-synthetic products. And other studies have shown us that companies that present a COA, a certificate of analysis, unfortunately are not trustworthy. They may be forged, or they may be from another batch and applied to this batch. But the fact that a company presents a COA, unfortunately, does not prove the point. There have been some attempts to regulate hemp products at the state level that largely have been blocked by the courts at this time. All right, so now we're going to talk about problems with the current policy. So we're going to start with a few exemplary quotes from patients of mine. This is an actual quote, as I mentioned, in which a patient came back and said to me, the bud tender said, "I don't know what your doctor's talking about. Don't listen to him. I'll tell you what to do." Another quote is, "They kept trying to get me to buy more. They have volume deals and push other products. And what's up with the prize wheel? This isn't the Price is Right." "He told me to add this keef stuff to my vaporizer, and now I feel sick, doctor. Why?" That was actually a call at 4 in the morning. "And you were right, doctor. They immediately suggested CBD. It's a good thing that you warned me about how dangerous this could be for me." This was of a patient who is on rejection drugs for having had a liver transplant, in which case the interactions with CBD and those medications could be problematic. The current dispensing system is fundamentally good for the industry. It allows for misdirection and misinformation. It allows for upselling. It allows for making false claims about medical benefits. God knows we saw lots of companies trying to market CBD as an anti-COVID remedy. And, unfortunately, the folks behind the counter, who I truly believe have the best of intentions, have inadequate medical knowledge to be answering the questions that are posed to them. And additionally, there is an issue of conflict of interest here because the advice is coming from somebody who's selling product. And we know that bud tenders have things like sales quotas or preferred sales products on any given day that do not then speak to the patient's benefit, but rather to the dispensary group's benefit. And these problems do not exist in the pharmacy and pharmaceutical world because over the last 100 or so years, we've developed some very strict regulations at the federal level that prevent this sort of behavior. One of the fundamental points here is that patients are not the same as recreational users, and oftentimes the goals are very much the opposite. For recreational users, the whole point is the ride, the intoxication, and they're interested oftentimes in what's new and exciting product-wise, and that experimentation with different products is part of the experience. For better or for worse, there's also a tendency towards the belief that more is better. And this, in fact, may be part of what's driving some of the studies that show a rise in cannabis use disorder in states with non-medical use programs. On the other hand, patients just want to feel normal. They don't want all of the intoxication, which for them is really a side effect. They just want to get back to feeling like themselves. That leads us to not more is better, but rather what is the minimum effective dose, or what is the least that I need to use in order to get the benefit? And of course, patients often have multiple complex medical problems and long laundry lists of medications to be managed and concerned about. The FDA took a position in early 2023, which to my knowledge is still their position on this. And they said, look, our hands are tied by the law of the land at this point, that we can only regulate with the use of data. Although now we're going to circle back to the data that they have recently analyzed. They also took the position that they're underfunded and that Congress expects them to take on an entire new area of regulation without any budgetary allocations. Also in January 2023, they clarified in no uncertain terms that their view for cannabis products and CBD was that they would be treated like any other medication through the new drug pathway. I think as an industry, the cannabis world has fallen prey to this, what I call the nutraceutical lie. In 1994, Congress, I think quite mistakenly, passed a law called the Dietary Supplement Health and Education Act, DSHEA, and this stripped FDA of regulatory authority over supplements other than to insist on good manufacturing processes and some post facto monitoring and enforcement. This empowered an industry that was based entirely on falsehoods without any need to prove safety or efficacy, turning into a $164 billion a year industry. These, I think, are 2020 numbers, so I'm sure it's only larger now. But interestingly, the United States Preventive Service Task Force, which is a process of the US government in which they review medical recommendations on a periodic basis, has repeatedly reviewed the science that shows that supplements have no value and occasionally cause harm in patients who do not have a measurable deficiency in a particular nutrient. This is, again, the model that is touted for cannabis products and marketing. It's fairly clearly not in the best interest of patients. It was rejected by the FDA in January of 2023, and we're sort of still waiting to see if Congress is going to take action either to entrench this model or to override it. I hope somebody's appreciating my little memes here. So what have we got in terms of the way of current progress? So there have been a number of bills introduced into the federal legislature over the years, and it shows some willingness to think about these issues, but nothing has passed. And we start with the Marijuana Opportunity Reinvestment and Expungement Act, MORE Act, which has been passed by the House 3 times, but never taken up in the Senate. It's focused solely on a combination of business and social justice issues. but no mention of patient care and really no regulatory framework, meaning that even had this been passed, there really wasn't any clear actionable outcome that would stem from it. Similarly, there's the Cannabis Administration and Opportunity Act that was introduced in the Senate. It's very business friendly, proposed some very, very heavy taxation, which probably made it unviable. It does have provisions for social justice issues, but it assigns medical care in, one measly paragraph in the 350 or 450 page bill that basically says, oh, FDA will take care of this, but again, no particular framework for their taking care of it, nor any budget allocation to do so. In short, really no discussion of healthcare and no acknowledgement that healthcare is a social justice issue. And then we get to where we are in the whole rescheduling thing, which has sort of turned into its own debacle. In 2022, President Biden instructed DOJ to review cannabis's Schedule 1 status. Now, DOJ or DEA has reviewed the Schedule 1 status numerous times since 1970, but has never obviously rescheduled it. The difference here was this was a directive coming from the president for the first time, whereas previously it had been under the impetus of lawsuits. The FDA and HHS, Health and Human Services, conclude for the very first time that cannabis has what's called CAMU, which stands for Commonly Accepted Medical Use. Now, you may recall that Schedule 1 is in part defined by having no accepted medical use. So this was the first time that our health and science agencies have acknowledged the fact that in fact cannabis has been used and is accepted, at least in a significant portion of the medical community. So that's a huge win. They then recommended moving it to Schedule 3. I suspect that in their hearts, Schedule 3 was not their first choice, but that it seemed as far as was politically expedient to try to move it at this time. Okay, typo in the next bullet point. DOJ instructed DEA to make formal rule changes to accomplish Schedule 3. The DEA then called for a hearing in front of an administrative law judge. And then the DEA has been accused of loading the witness list with anti-rescheduling groups, which, if you look at their list, does in fact seem to be the case. But unfortunately, due to the accusation and lawsuit, the result was that the hearing was canceled, and there's no clear plan as of yet what should follow. So at the moment, these proceedings have sort of ground to a halt, and it isn't clear what's next. And of course, we now have a new administration where the president has certainly in the past made statements in support of cannabis, or at least medical cannabis. He's also made statements against it in the past, and he seems to be nominating people to run both DEA and DOJ who've made very recent studies, statements about how little they think of cannabis as an option. It's also important for us to note that the effect of rescheduling will not accomplish all the things that everybody was hoping for. It will make it easier to do research, particularly clinical research, and it will eliminate some of the 280E tax burdens that are presently on companies, but it will not make state-led legal cannabis federally legal. It will not unify states' programs, resolve the cannabis hemp disparities, or create a national cannabis medical program, nor will it make cannabis a prescribable medicine. Even if it's on Schedule 3, it will not be an FDA-approved drug that would then be a prescribable medication. So, what are our ways forward? Well, let's start with what should a federal medical system provide? These bullet points are foundational to the Association of Cannabinoid Specialists and are embodied in a white paper that we published in 2018. So none of this should be news to anybody. But what we think is, number one, that we need to have exact prescriptions. We need to be able, as a provider, to be able to say what it is a patient should get how much to take and when and by what route, all the things that we would do with any other medication. Similarly, those prescriptions need to be binding upon the sales agent so that there is no changing without consultation with the prescriber, no upselling, and those sorts of things. We need a moratorium on medical claims that are not substantiated. We need state-to-state interoperability so that patients can travel with their medications and even get refills in a host state. We need common safety standards so medications purchased in Florida are equally safe as they might be in New Mexico. We need to reinstate clinical discretion, meaning that medical professionals should not be bound by a list of conditions that were put together through a political process, but rather should be required to know what they're doing and do it properly. We need some form of purchase feedback information like the prescription drug monitoring programs, PDMP, which exist for other medications that allow us to have some idea of what is actually being purchased and sold. We also need to understand that recreational or non-medical systems will overlap in some ways, and we need to address that again, particularly in light of not giving medical advice or upselling products in the recreational arena. And lastly, we need a robust research agenda that is well funded so that we can continue to move forward with gaining knowledge that we can apply for our patients. So to do this, there are a number of proposals out there. ACS has put forward something that we're calling COL 2.0. The idea here is that it is a short-term policy that we think is possibly attainable and a way to achieve improved national policy because it doesn't require a lot of new infrastructure or budget allocation. It unifies state programs without substantially changing the business operations in those states, and it bridges the gap between the currently shrinking medical programs and the ultimate development of pharmaceutical medications. Under this proposal, the COL 2.0 would stipulate non-enforcement of federal cannabis law predicated on some of the ideals from COL 1.0 and a few new points. The old provisions are just the same as we saw up above, so I'm not going to read the whole list, but I told you back then that I wanted you to remember the last one, the preventing possession on federal property, and that one needs to be eliminated because we know that many of our patients, in fact, many of the sickest and most deserving of our patients live in federally subsidized or Section 8 housing, and presently they are precluded from getting and using medication in their homes. So that needs to go away. The new provisions in our proposal of 2.0 would require that states modify their programs to have that specific binding prescriptions following the generally accepted format, require clinicians to take accredited CME about cannabis medicine on a periodic basis. And I should clarify that that requirement should be of clinicians who are prescribing cannabis, not necessarily every clinician everywhere, and that we need to be able to allow patients to travel with their medication across state lines and get refills when needed. Additionally, COL 2.0 would have to provide non-enforcement protections for states' non-medical programs, provided the state's programs are modified to prohibit non-medical establishments from giving or implying medical advice, which is a major problem at this time. So that is what I wanted to talk to you about today. I want to briefly give you a few more details about the association. We are an international organization of healthcare professionals focused on providing cannabinoid medicine at a high standard. Our membership benefits include advocacy, education with events, as well as some on-demand kind of educational coursework, networking, and various events. So if you want to learn more about us, you can go over to www.cannaspecialist.org to learn more. I thank you very much for your time and attention today, and I hope you have a wonderful conference.